Welcome to The Pursuit of Health, the podcast of Americans for Free Choice in Medicine. Joining me today is emergency medicine physician Dr. Colleen Smith. Colleen will be sharing with us today her story of how she got into the field of medicine and what she is doing to advocate for herself and her values within the American healthcare system. Colleen, welcome to the show, and thank you for sharing your story with us.
Thanks, Ray, and I'm happy to be here.
All right, so let's start at the beginning. How did you get into medicine in general, and how did you get into emergency medicine in particular?
Well, to describe how I came to medicine to begin with, I have to go back a little bit farther and touch on my background a little. So I grew up mostly with my dad, who retired from the Marine Corps after 30 years around the time when I was born. And I have these vague memories even of him when I was a child, when he was in college, which the Marine Corps paid for after he retired. And when I was young, we were really poor. We ate beans and rice many nights for dinner. I remember being excited when we would get this huge block of Velveeta cheese from the food pantry because it added a little flavor to the meals. By the time I was in high school, we were a little bit better off, but still surrounded by family who were not particularly well off, and we still struggled from day to day. I still got my clothes secondhand, and if the car broke down, we might go a week without a grocery run and have to scramble around in our pantry for whatever leftover food we could find. The other thing that's kind of interesting about my dad is he wasn't the typical military dad in the sense of like, I had to make the bed with hospital corners, although he did teach me how to do that. But he took from the Marine Corps this sense of an identity that was built on the importance of excellence, hard work, strength, endurance, and facing adversity with all of these things in mind. And he would say all the time things like, if you decide to do something, for example, when I decided I wanted to play trombone, you have to decide that you're willing to put forth the time and effort that it takes to be excellent at that thing. And so I kind of went through high school with this sense, a little bit from him, that I needed to work to try to be independent, that it was possible to have a better life for myself and make a better life for myself than the one I was in, even because I had seen him slowly over time make a better life for us. And also that I had some control of my destiny, and that if I was willing to put forth the work and the time and effort that it took, I could build something better for myself where I didn't have to scramble to go a week without food, or where maybe I could go on vacation with my family. And so when I went to college, I kind of went with that in mind. And although I didn't focus on medicine in college, I knew that even just having that degree would be enough, that I would be able to get a job that would pay well enough that I could kind of afford to have a life. So after college, I did get a pretty good job managing clinical trials in oncology at the University of Chicago hospitals. So one of the major academic centers in the country, running some of the cutting edge clinical trials in oncology. And I was doing administrative work, but a lot of that work meant that I needed to learn about medicine and how clinical trials were run. And I saw what happened to patients. And one of the things that I got to do was I was really the administrator for organizing this weekly conference where the surgeons and oncologists and pathologists and radiologists, top doctors in their fields, would come together and talk about each patient who was beginning their course of therapy for whatever cancer they had. And it was just fascinating to me to learn kind of about how cancer was treated, but even more than that, to watch these expert clinicians discuss each patient in the tiniest of details, from taking into account subtleties of their diseases and what kind of work the patients did, deciding on medications and surgeries and therapies. It was just so fascinating to watch this happen. And I think over time, the doctors began to realize that I was interested in more than just organizing the conferences. And one of the surgeons, I'm not actually sure if it was just the surgeon. I think maybe one of the oncologists was involved in convincing the surgeon that he should do this, but he asked me if I wanted to go to the operating room with him and observe a surgery. The surgery was a Whipple, which is one of the most difficult surgeries that's performed, where many organs, including the pancreas and part of the stomach, are removed. And I went to the operating room. And this is like, for me, the memory of that is one of those pivotal memories that kind of sticks with you for your whole life, that changed the course of my life, going to that operating room. The smallest details, like they stapled the sterile drapes to the patient, or I got to see organs, like the inside of someone's body for the first time ever, like their intestines and their like their liver. And it just, I never thought I would ever. It was not even something that had entered my mind that I would get to do. So even those small things, to watching this surgeon who was calm and competent and teaching in the middle of this really difficult operation. The whole thing, I was enthralled. And in a sense, that trapped me. I had to become a doctor. And so it was really just how amazingly intellectually stimulating the profession was. Just the lifelong pursuit of learning, the degree of dedication, watching someone who was just so competent in their field be excellent. And then on top of that, doing this job that's so intellectually challenging and stimulating also meant that I would be helping people. So those two things together, I had to go into medicine. And then emergency medicine really came because the same things that were amazing to me when I was managing clinical trials in oncology and going to the operating room, I got some bit of all of that in emergency medicine. So I see completely undifferentiated patients every day. And although now that I've done it for 10 years, most of those patients fit into a box, every now and then I still see a patient that surprises me, that I don't know what I'm looking at. And I really have to be thoughtful and considerate and start the process of solving a mystery. And I don't always get the answer, but it's still just really fascinating. I get to teach patients and residents on my shifts. I learn more by teaching. I meet different people all the time, from patients with in New York City in particular, from uncountable backgrounds to even just the specialists in the hospital who, as an emergency medicine doctor, I'm seeing a little bit of everything. And so I'm interacting with almost every medical specialist and learning from them and with them. It's a fascinating specialty. And then occasionally I do have a patient who's very, very sick. And the years that I put into residency and into training to be able to remain calm and be able to focus on the essentials of a situation and have endurance in a situation that is stressful, where literal life and death is on the line. I'm really proud of being able to be good at that. And there's some adrenaline that goes with it every time. And a lot of times I help people in ways that even other doctors wouldn't be able to do. And so that is really just, I don't know, it gives me a real sense of pride in my accomplishments and what I've been able to do.
What would you say are the challenges that you've faced in your pursuit of this career that you've chosen?
So there's a variety of challenges. I think just to begin with, just going back to what my dad always said, this was really a career choice that for me, there needed to be something that made it worth it, because it is difficult. The training is difficult. It's many, many hours. And even after training, it can take a lot of your time, and you really have to be dedicated to continue improving yourself. And so in that setting, balancing a career as a physician with life and family and friends and work can be really difficult. For me, it also became a bit of a health issue. And so I had to step back and slow down, and I work less now. But I think ultimately coming to the realization that working less would not only be good for my health, which doctors are pretty bad at doing the right thing for their health in general, also kind of came along with this realization that working a little bit less would also be good for my relationship with my children. And in fact, it has really been phenomenal to have a little bit more time with my children now that I'm working less and my family life has gotten much better. So I think that I wish I had been more deliberate. And I think the moral thing to have done would have been to be more deliberate about balancing that family and career time. And I think this is something that kind of happens in your life. You really do have to be thoughtful and deliberate about what your values are and pursue them. And for me, my family is a real value to me, that just as my career is a value to me, just as being a doctor is a value to me. Because I worked full time for many years, I built relationships with many residents who went on to become colleagues and with many doctors in different hospitals throughout the city. And some of that was I worked in different hospitals. I did a fellowship at one hospital and then I went to another hospital. And a little bit of my changing hospitals was me finding a position that felt right for me, where I fit and I felt that I could practice medicine the way that I thought was right for my patients. But even still, I tried to not burn bridges as I did that. So now that I'm working less, I am able to have a little bit more control over doing that. And I'm able to work at places that I know that I share kind of a similar philosophy of how best to take care of patients. And so I don't know that I would have been able to work the way that I am right out of residency, for example. Nor do I think that it necessarily would have been the right choice, because there's so much learning that happens your first few years out of residency. And there's something to be said for really working a lot those years because you get so much better as a doctor. I think there's really some sense in which you have to consider many different factors in your career and life as you make these decisions about what you do with your life. And I mentioned that now I am able to choose to work occasional shifts in hospitals where my colleagues share a similar philosophy about how to take care of patients. And that is another major challenge that I faced in this career, in being an emergency medicine doctor. And that is that in some practice situations, there are different kind of levels of protocolization. And sometimes that can be too much. And there are different opinions about what's acceptable and what's not acceptable in terms of kind of deviating from standard of care. And that's not to say that I deviate from standard of care very often. For the most part, I try to practice very evidence-based medicine. But often there are protocols that come from insurance companies or Medicaid or hospitals or various supervising bodies, and they don't always take into account every individual patient situation. And so there really can be, depending on your situation, a lack of flexibility in the protocols that can lead to situations where following the protocol is not right for your patient. And it's been really important to me to be in a place where if I do deviate from the protocols on those rare occasions when it isn't right for my patient, in particular if it could be detrimental to their health, that I have support of colleagues and supervisors in the hospital to do that. I think there's all this talk now about moral injury, and one of the major components of moral injury is when doctors are forced to make decisions about how they care for their patients that are based on things like whether the hospital will make money or not, or whether insurance will pay for this care or not, rather than what is the right thing to do for my patient in this moment. So for me, it's been a matter of just finding practice environments where I can take care of my patients for the most part, as I think it is appropriate to take care of my patients. So just to make that clear, one example of that is sepsis care. So sepsis is when you have a really bad infection, and because of this infection, the tissues of your body aren't getting the oxygen that they need to function properly. And the Center for Medicare and Medicaid Services has this sepsis bundle, and they pay for sepsis care in a bundle. And you have to meet certain specific goals in order to get paid for taking care of a patient who has sepsis. And those are things like they got 30 cc's, 30 milliliters per kilogram of fluid, and they got antibiotics in the first hour, and you sent blood cultures, and you checked a lactate. And most of those things are fine and easy to do, and the antibiotics are really important, and I agree that that should be there. But the fluids are a real stickler, and almost any emergency medicine doctor will tell you this. Probably 80 to 90% of our patients should get those fluids. But there's a small subset of patients who also have things like end-stage renal failure, where they go for dialysis 3 times a week to get fluid removed from their body because their kidneys don't work anymore. or heart failure, where they have to significantly limit their fluid intake or their lungs fill up with fluid and they can't breathe. And those patients really need to be treated differently because if I give them 30 cc's, 30 milliliters per kilogram of fluids off the bat for their sepsis, I'm also likely to have to intubate them because I'm going to cause their lungs to fill up with fluid. And it can be very difficult. Only, I think, in the last year, there have begun to be ways to document that the patient should not get this fluid. But for years, the choice was get paid for providing high level critical care for your septic patient who's very, very sick, or don't get paid for providing that same care. And I think that's really a bad situation to be in. It's a terrible situation to be in. Doctors deserve to get paid for the work that they do, especially on these very, very sick patients. But if my choice is to get paid or to worsen my patient's outcome, I'm going to choose not to get paid.
Mhm.
And it's really an unfortunate situation to be put in as a physician. And then what is going to happen next is the hospital administrators are going to come and find me and tell me, you are falling out on all of your sepsis care. You're not meeting guidelines. And I'm going to say to them, I didn't give fluids to these patients because it would have been detrimental to their health. But that doesn't matter to the hospital administrator, right? So I'm put in this really impossible position. And that's really kind of where this moral injury comes from.
Right, where you experience the system as putting you in a position where you have to choose between acting in ways that you regard as good. But if you don't, then the system will penalize you for some reason.
Exactly.
And I think that's an experience that a lot of physicians and other people in the healthcare system can relate to.
Yeah. And again, I'm lucky because the two hospitals that I primarily work at now, both of those hospitals, the emergency department directors have for years said, my goal for you is to take care of patients as you think is appropriate. And I will deal with the fallout of you not meeting sepsis guidelines because you're taking care of your patients appropriately. But that doesn't happen in every emergency department.
The other aspect of protocols is not just that you can have these situations where you're faced with a certain kind of moral injury, but you get the sense of the erosion of clinical judgment. Now, of course, protocols have their place and they can be very useful. Talking to other physicians, you can get the sense that it's your judgment versus the protocol.
Yeah, I do think that definitely happens. As someone who teaches residents a lot of the time, I spend a lot of time talking about protocols and scores. There are all sorts of scoring devices that help us decide should we admit this patient or should we do this next test. So I spend a lot of time in my teaching talking about how important it is to understand why protocols came about, what they're based on, what the scoring guidelines are based on, whether or not they're appropriate for your patient and why, what's the population that they're based on. But I do think that there are definitely situations where it is easier to fall back on the checklist or the protocol than to do the work of thinking beyond it and really understanding where it comes from. And that is really a necessary part of, I think, being a good doctor is understanding where it comes from, because only through doing that can you understand whether it applies in any particular situation and when it's safe to deviate from it. But that just makes teaching that much more difficult. It makes teaching residents that much more difficult, right? It makes the whole process that much more difficult.
And it also changes the experience of being a doctor because if you feel like you have to follow all these protocols and you don't know where they're coming from, you might get the sense of, I feel more like a bureaucrat than someone that's providing care.
Yeah, I do think that's true. I think that comes a little bit more in other specialties when we talk about things like the administrative burden, which comes with it. And I'm fortunate in emergency medicine that I don't have to deal with a lot of that administrative burden, but certainly almost all other specialties in medicine do. And I think people often find that they feel more like an administrator or a bureaucrat, or they're just ticking boxes rather than taking care of patients.
Would you say that that's one of the selling points of being in this specialty?
Definitely. Yeah, absolutely. I have never had to do a prior authorization request for a patient.
And how about what you're doing now? What are you doing now to pursue values in the healthcare system?
Now that I'm working a lot less clinically, I've been taking time to do some things for myself, which has been great, focusing on family, hobbies. But one thing I've always wanted to do a little bit more of is writing about medicine. So I've started my own blog where I'm trying to write about medical education and some of the absurd things that happen in medicine that are funny and surprising.
What's the name of the blog?
It's on Substack. It's just Dr. Colleen Smith. I have several ideas. I'm slowly putting things out. And then I'm also starting to try to write for AFCAM because one of the things that is great about medicine in our country is that there's some degree of freedom there. And a lot of amazing things come out of that freedom, drug developments and vaccine developments, and just all sorts of amazing innovation. Even in sort of the telemedicine world, there's been a lot of innovation because for a while that had been more free. And I think the more that we can champion freedom in medicine, the more medicine will improve for patients and doctors. And so I'm trying to do a little bit of writing for AFCAM, both because I think it's important to work to keep the freedom that we have in this country, but also because selfishly for me, it's an opportunity to improve my writing, to really grapple with new ideas, not necessarily new ideas, I guess, but really grapple with ideas and really try to understand for myself what is going on in this convoluted healthcare system that is American healthcare that we have. So I'm hoping to learn a lot more about healthcare, but also get better at expressing ideas and writing and improve my writing and further this idea of freedom in medicine.
And what are some of the topics that you're interested in writing?
Well, right now I'm writing a little bit about prior authorizations, largely because I've run into it as an issue as a patient more so than as a doctor. And then I'm also doing some writing on direct primary care. And the reason for that goes back a little bit to the question that you asked me about before about challenges that I faced. So when I had to stop working as much for health reasons, I was thinking for a little while about trying to go into primary care, open a small urgent care practice that would be direct pay. For example, I could do urgent care in my building and maybe keep people out of the emergency department. And that could be easy. And I could charge like really not that much money, relatively reasonable rates to do something I enjoy doing that would help people and be kind of fun for me, right? But it turns out that if I'm accepting payments in cash from patients, I can't accept those payments from patients who have Medicare or Medicaid as their insurance. And I also have to opt out of Medicare and Medicaid. If I opt out of Medicare and Medicaid, I can no longer pick up moonlighting shifts or per diem shifts in any of the emergency departments that I work in because they need me to be able to accept Medicare and Medicaid in order to get paid for the patients I see in those hospitals. And so there's this real lack of ability to transition to a different type of work after having completed an emergency medicine residency and also a lack of ability to accept different types of work at the same time. So I can't do direct primary care and except for people who voluntarily might pay me and at the same time have Medicare and Medicaid because I risk being charged with Medicaid fraud. And certainly there would be no place in my mind in which I'm trying to defraud Medicare or Medicaid. Literally, I would just be trying to help people. But if someone gave me money and didn't tell me that they have Medicare, I can get in trouble for it. And so it's just not feasible for me to do something like that. Or if I wanted to go into primary care, and probably 80% of what I do now is some version of primary care. Theoretically, I should be able to take some classes in continuing medical education and learn some of the things like preventative care, things that my primary care doctor does, or long-term management of blood pressure, which I know to some degree because I see those patients, but I don't do it all the time every day. But I can't do any sort of modified residency, or there's no process for that without doing a complete new internal medicine residency, which I'm just not willing to do again. It's not worth the time and effort for me.
Which is a
You know,
real
I think,
shame. Like that also harms other people because there's a shortage in primary care physicians, and there's people who would be willing to switch over to that specialty.
right. And certainly, I think I could probably be a great primary care doctor, especially for younger patients who don't have multiple comorbidities, who really most of their healthcare would be urgent care type of healthcare anyway. One thing that makes a doctor a good doctor is knowing what they don't know. And so, right at some point, I certainly could say to a patient, I think your clinical complexity is too much for me and you should go see someone else, right? But there's no real path for transitioning in medicine at this moment in the US. So anyway, direct primary care is one take on some of this, but I'd like to write about it because I think it's one area that could be made a lot better and open up opportunities for more primary care providers, more ways to pay for medical care.
It's reaching doctors who not only care about these issues, but want to write about it themselves because it affects their lives is
Yeah.
certainly something that AFCAM wants to promote going into the future. And with that, thank you for sharing your story.
Thank you so much for having me, Ray.
To stay up to date on our newest episodes, subscribe to our show from whatever podcast platform you are listening from. To support our show and Americans for Free Choice in Medicine, you can make a financial contribution at www.afcm.org/donate. Thank you for listening.